The contemporary issue, the development of nurses in primary care to advanced practitioners and the barriers. Aims of this presentation include as follows. Since starting my journey within the nursing field, it has always seemed challenging to progress towards the goal of an ACP for many reasons, including organisations being quite obstructive for nurses to progress in their clinical field, whether it be related to funding shortages, staffing, support shortages, or a reluctance for employers to support an advancing skill set to nurses. Scenarios such as mine are not uncommon in present times, but the struggles experienced by nurses to progress clinically is a long-time issue that dates to before the inception of the National Health Service in 1948. The NHS was created at a time when the Second World War had finished and the needs of the population post-war were extreme, resulting in the innovation of a healthcare system aimed to support the whole population and not just those that could afford it. The history of nursing advancement can date back to the 1950s to iconic figures such as Florence Nightingale, also known as the Lady with the Lamp. Florence Nightingale's efforts to improve patient care during the Crimean War resulted in a fund being set up that was subsequently used to establish the Nightingale Training School in London in the 1860s. The Nightingale Training School was the first funded nursing training available within the UK, symbolising the foundation blocks leading to advancing practice in the nursing profession today. Since the inception of nursing, the responsibility and professional evolution of advancing practice has evolved through time through key moments, legislation and reports, some of which will now be discussed. Firstly, in the Samrin Report in 1966, this was from the infancy of the new healthcare system, recognising a requirement for training to be standardised across the NHS. Following this was the New Horizons in Clinical Nursing Report in 1975, which provided the first glimpse into the concept of advanced practice. In the 1980s, after the nursing profession began to review global healthcare systems and nursing structure, they found that advanced practice was already well integrated in the United States, highlighting that the UK was falling behind with the times. Over 10 years later, the UK Central Council for Nursing and Midwifery recognises that nurses can work at higher levels of clinical practice, management, practice development and leadership. Lastly, after nearly 20 years, the RCN standards for advanced level nursing practice became available in 2018. These standards try to set out clearer guidance as to what is required of nurses to work in advanced practice within the UK, also recognising that from 2018 onwards, in order to achieve this at a recognised level of practice, the nurse must obtain a master's level degree. Returning to the contemporary issue, barriers to nurses in primary care progressing to advanced practice levels are multifactorial. Some of these have been detailed in the timelines previously discussed, but further barriers can be broken down into political, economic, social, technological, legal, and environmental. We will start by considering the timeline of the political leadership that has taken place for the past 80 years and the consequential reports, effects on the economy and the social challenges that have taken place in these periods. During Conservative leadership, the Beveridge Report in 1942 was published, which proposed free national health service and consequently led to basis for change under Labour by forming the initial configuration of the NHS. A lot was covered within this report, but crucially is the recognition that there will be a rapid increase in population growth and the age of the population, identifying the start of key pressures which are present on the NHS as a whole and more specifically primary care nurses to this day. Following this, there was the contrasting economical ideas from Keynesian economics that dominated policy making in the 1950s and 60s, which focused on the state as well as the private sector. Shortly following this was the winter of discontent, minor strikes and formation of the New Labour, among others. From a nurse's perspective, during the 1960s, nurses received a 20% pay rise through the RCN campaign, and subsequently under Margaret Thatcher's leadership, we began to move the education of nurses from within the NHS to the university level of study, and made the huge transition to training nurses being supernumerary. This change is a crucial landmark in nursing history and remains a significant issue for modern day training nurses due to lack of nursing staff and patient pressures, a concern that will be discussed in more detail in this presentation. Moving forward into the more recent period of the past 20 years, further substantial changes were made in the NHS, such as the introduction of non-NHS contracts, the inception of local health authorities, and the integration of Care Quality Commission, and finally leading to the Health and Social Care Act 2012, where nursing became a graduate entry profession under a Conservative government. The change from diploma to graduate level nursing has subsequently been shown to improve the mortality outcomes for patients in the inpatient setting, as shown in more detail on this slide. This is a significant outcome from the evidence, but unfortunately there are no equitable findings in relation to primary care nursing. The development of nurses clinically has largely been because of the changing needs of the population and the staffing medical shortages within the NHS. The British Medical Association has calculated that while other countries have more adequate medical cover relative to the population size, or an assumption of 3.7 doctors per 1,000 people, the UK falls significantly short of this and would need an additional 46,300 doctors to meet this estimated need for the population. In primary care, between December 2016 and December 2021, there was a recorded reduction of over 1,500 general practitioners within the United Kingdom, recognising a further increase in patient burden to doctor ratio by 11%. The result of these significant reduction in doctors' numbers has contributed to the development of advancing practice for nurses to try and bridge the gap for patients' care. This is not to say that nurses in advanced practice roles are there to replace doctors, but with the advanced skills that nurses are able to obtain, aids in supporting the clinical workforce inadequacies. A qualitative study relating to the ICPs transforming the workforce in primary care confirms their positive contribution to meet patient care needs, but also recognises the need for advancing roles to be seen as more than a gap fill for healthcare and should be innovating the transformation of services on a wider scale. This study has some influential outcomes in relation to the topic and is relevant to the sector of primary care which has been discussed. Comparatively, a 2022 cross-sectional survey of both primary and secondary care ICPs reviewed variations in the role, job descriptions and frameworks and governance from one NHS organisation to the other and found substantial discrepancies. This demonstrates a significant barrier for nurses to progress in primary care, as this raises concerns for employers over how they will govern ACPs in primary care, leading to a gap in support for ACPs from the primary care organisation to which they are employed, and a feeling of vulnerability to primary care organisation when taking on an ACP. The definition of Health Education England and advancing practice is as seen on this slide. Non-medical prescribing is now an imperative part of the clinical skills needed in advancing practice and is a mandatory part of the 3-year university degree for advanced practice. This skill was not always available for nurses to complete and began with a recommendation from the Cumberland Report in 1986, which recognised that patient treatment could be enhanced if nurses were able to prescribe from a limited list of items. It took more than 6 years for the recommendation to come to fruition, and following these changes to legislation there were multiple reviews and reports, which penultimately led to the introduction of independent and supplementary prescribing, V300, which now allows nurses to prescribe from the British National Formulary if this is within their area of competency. Barriers to the advanced practice role were not only from a policy and funding perspective, but also due to patients' perceptions of the role as it has come to the forefront of the NHS. Care. A literature review conducted in 2021 of the ICP roles within the UK identified the main challenges in patients' acceptance of the ICP role in primary care, which was lack of understanding of the role. Interestingly, the study also confirmed that despite the lack of comprehension of the role, the patients who did have consultations with ICP showed high levels of patient satisfaction of care. This shows an unclear connection that once patient barriers have been dissolved, the interaction with ICPs can be a positive experience. In 2015, NHS England formulated a new care model introducing vanguards into the various care settings to not only try and deliver the NHS 5-year forward vision, but more specifically in South Yorkshire, forming a working together partnership to help recruitment and retainment of specialist staff in this area. Again, from a local perspective, in 2015, South Yorkshire and Bassett Law Faculty Advanced Clinical Practice formed to try and bring structure and support to those already in advanced practice roles, as well as those wishing to pursue this career. This formation of the support system for advancing clinicians seemed to be timed perfectly, in line with the NMC new code brought out at the same time. The new code providing requirements for nurses to revalidate and provide ongoing evidence of their professional development and learning, with a heavy focus on working within your scope of competence. Coincidence that all of these occurred at the same time? or a local reaction to the realisation that ACPs are becoming the forefront of nursing development from deficits in NHS plans. The 4 pillars of practice underpin all competencies regarding advanced practice. More specifically in relation to nursing, a nurse who undertakes advanced practice are still registered and governed by the NMC. The NMC Code of Conduct outlines the core principles and expectations of nurses in this profession, but has not yet generated a separate code specifically for advancing practice. On completion of additional competencies such as non-medical prescribing, the clinician is able to begin prescribing until this is added to their registration with the NMC. The NMC also encompasses the Royal Pharmaceutical Society's competency framework, which clinicians must adhere to alongside the core NMC standards to remain a registered prescriber. The opportunities for clinical advancement in nursing to master's level is becoming more and more prevalent, with a significant shift in perspectives and realisations of the potential for advanced practice within the healthcare system and how successful they can be. Unfortunately, despite this realisation by the healthcare system, and advanced clinical practitioners still currently remain a title that is not yet registered with a professional body. Therefore, this is not currently a legally protected title. For the most part, this title's lack of legal protection results in a feeling of risk for practitioners and can lead to a vulnerability for the advanced practice clinicians in potential circumstances regarding litigation. A survey conducted by Health and Care Professionals Council identified that this feeling of vulnerability or lack of protection was felt by many of the clinicians within the advanced practice field, and cementing a further barrier to progression of nurses to ACPs in primary care due to the very real autonomy that this means for the ACPs and the feeling of "am I protected?". Fortunately, in 2017, Health Education England produced a 23-page document on multi-professional framework for advanced practice in England, providing clarity on their role and accountability, which was previously unclear. The NHS 5-year forward view recognises that the NHS is in a stage of evolution, particularly within general practice, with a plan of multi-speciality community providers involving the encouragement of larger GP practice with specific services targeting patients with complex needs, including frail elderly patients and those with chronic conditions. The General Practice Forward View recognises the benefit of the advanced practitioner in general practice, and the Primary Care Workforce Commission report detailed recommendations to increase roles of advanced clinical practitioners within primary care as well as other professions. The very specific factors to consider for barriers to an ACP in primary care is also linked to the individual clinician. There are abundant external factors that have been critically discussed, but the most intrinsic factor is the competence, experience and skill of each advanced practitioner and how they apply this to their role or training. A key aspect of this is critical or clinical reasoning. There are multiple clinical reasoning theories available to clinicians, but all of these have their strengths and weaknesses, interpreted by the individual clinician. One example of this is the inductive approach, which allows a clinician to reach a direct conclusion after taking all information, but it has its weaknesses in that it is not time-based, therefore unsuitable for use in primary care setting with time-based appointments. In contrast is the deductive approach, which sets up a desired goal to then find the supporting information behind this. An effective approach, but one that can lead to information bias and misdiagnosis, especially in the new practitioner. The most common clinical reasoning framework is the dual process theory, which, for the more experienced ACP, the concept means there is a link between a clinical situation and the long-term memory of past experiences, which the clinician uses to formulate quick diagnostic conclusions. Again, the risk of this model is the consideration that this incorrect judgment or rapid conclusions from past experiences can lead to misdiagnosis, but a rule-based decision-making process is more appropriate for novice clinicians such as myself. The correct clinical reasoning is vital in the nurse training to ACP in primary care due to the isolation and significant autonomy that is present in the primary care sector. Individual consultation rooms and no direct support or supervision that can generally be expected in a hospital setting, demonstrating the last barrier in the development of nurses to ACP in primary care. Nurses are training to advanced levels at much junior levels of their nursing journey. Therefore, do nurses feel they have the past experience to have the level of autonomy that is required in primary care to make these clinical decisions? The following personal SMART action plan has been completed. The transition from the beginning of nursing, where they had no voice in a medical-led healthcare system, to now studying to a level where they can now diagnose, diagnose, commence treatments for patients working alongside their medical colleagues rather than below them, has changed the trajectory of nursing forever. Where this path leads us nurses in the next 50 years, we don't know. As always, we will grow with the role and rise to the needs of our patients.